Hi, this is Stephen, and in this video we will continue our study of diastology, or how the heart fills with blood, the left ventricle in particular. And in this video we're going to put together two concepts in previous videos. So in a previous video we talked about tissue Doppler, how we can look at the velocity of the left ventricle at the edges and see whether it is appropriately moving in diastole or not. And we said if there's any abnormalities in motion, there is some kind of diastolic or filling problem. We don't know what type necessarily, but there's something abnormal. And then as you can see in this information I have here on the screen from our previous video, looking at the mitral inflow, there's different patterns of the blood flow coming in through the mitral valve to the left ventricle. There's this normal pattern with a good amount of blood flow early and then some late. And then there's impaired relaxation where more of the blood is coming late in that atrial kick. And so atrial fibrillation could be a problem there for the patient. There's the pseudonormal pattern where things look normal, but actually it's because there's a push from the left atrium into the left ventricle rather than a pull from the left ventricle, pulling blood flow in, as would be healthy. So we call that the pseudonormal pattern. And then we talked about the restrictive filling pattern, where again, blood is blasting in. Both the pseudonormal and restrictive filling pattern typically have elevated filling pressures of the left ventricle. And we talked about how you can use Valsalva. If you're not sure is somebody a normal pattern or a pseudonormal pattern because they look the same, you have them do a Valsalva and see if the pattern changes. If the pattern changes to impaired relaxation, that's just pseudonormal. So that's all a recap. The reason I've kept this screen up is I want to show you how we can put together our tissue Doppler and our mitral inflow for some very useful information. And so let me just clean this up a little bit here. We'll remove this with Valsalva. And what I'm going to do is I'm going to actually draw in the tissue Doppler in blue. I hope this won't become too busy, but so right down here. So if we had let me get us a different color here. Let's get this purple. Okay, so we can measure tissue Doppler right here. Or we can measure tissue Doppler, and in fact we usually do it in both, right there at the lateral aspect. And in a normal patient, you'll see a nice sized E prime wave, and then you'll see a nice size A prime wave, with the timing close to when the E and A wave are. I'll draw it exactly the same just for simplicity. E wave and A wave. And what do we say on tissue Doppler? We said that for any type of diastolic dysfunction, whether it's impaired relaxation, pseudonormal, restrictive filling, your E prime will go down. And so I'm going to exaggerate this a little bit, but we'll have a smaller E prime, smaller A prime, small E, small A. And similarly, for this pseudonormal pattern, we'll have a small E prime, small A prime, small E prime, small A prime. And let me actually just label these here. So E prime is over here, and A prime is over there. E prime, A prime. And same thing down here for the restrictive, small E prime, small A prime, small E prime, small A prime. How can we use this to our advantage? Well, what if we were to take a look at the ratio of E over E prime? That actually can tell us a lot about how the heart is filling. And so just for a little bit of clarity, I'm going to draw down here. So again, we got our left atrium that empties via the mitral valve into our left ventricle, right atrium. And so we said that for tissue Doppler, we wanted at least 6 when we measure here. The septum, we want this to be at least 6 plus. And we said when we measure here, at the lateral aspect, we want this to be at least 7 plus. The tissue should be moving at least that many centimeters per second if there's normal function. Similarly, for E over E prime, we want, so E over E prime at the lateral aspect should be less than or equal to 13. Units cancel out because it's a velocity. And here it should be less than or equal to 15. Or if you average Instead of looking at 13 and 15, you could say on average it should be less than or equal to 14. Let's try some numbers. So if I come back here, what did I say? I said that a normal E velocity would be like 100, right? Up there I say normal E would be 100, and a normal E prime might be 10. And so if we say E equals 100, remember the flow of blood is much faster than the flow of tissue, and if we say E prime equals 10 centimeter per second, what would E over E prime be? E over E prime in that case would be 10, which is normal, right? We said that on average, if your E over E prime is less than 14, that is normal. There's actually an interesting equation that some people like to use where you say your E over E prime plus 4 can give you an estimate of your left ventricular filling pressures, or your wedge. We'll say that's an estimate of your wedge pressure. But nevertheless, so E over E prime 10, that's less than 14. That suggests that we're dealing with normal filling pressures. Now, what if instead, we're going to scroll up here. So what if we're looking at this pseudonormal pattern, this pushing, when your E is again, your E is good, it's 100. The E and A waves look exactly the same as it did in normal. But now let's say that your E prime is decreased. Your E prime is down to 5. So let's say if our E wave, oops, let's get this out of the way, sorry. Let's say that now if our E wave, so this we'll say that this previous one was normal. Let's say that our E wave is still 100 because our E and A wave look the exact same, but our E prime is 5. And right off the bat, when we see that our E prime is reduced, we know something's wrong, whether it's impaired relaxation or pseudonormal or restrictive, something's going on. What's our E over E prime? Well, now our E over E prime equals 20, which is abnormal, which means we have elevated left-sided filling pressures. Elevated left-sided filling pressures. So this E over E prime concept is very useful. Sometimes, we talked about here with the mitral E&A concept, you can use a Valsalva maneuver. Patients aren't always able to do that, and so you're stuck trying to figure out, am I dealing with normal versus pseudonormal pattern? If you take E prime and combine that with E, this is a very useful way to estimate your left-sided filling pressures, whether you just look at 14 and above as abnormal, or whether you use this equation, E over E prime plus 4, to estimate the wedge. The only caveat that I'll mention with E over E prime is that this is, we can't use it. Can't use if there is severe mitral annular calcification, or if there's a prosthetic mitral valve. But otherwise, you can use this in normal ejection fraction, you can use this in reduced ejection fraction, you can use this in AFib. And actually, on the subject of ejection fraction, many of the other parameters that we use to estimate left-sided filling pressures cannot be used if you have a normal ejection fraction. This is one of the few ones that can be used with a normal or reduced ejection fraction. And the average value, one more time, should be less than or equal to 14.